Well, good afternoon, everyone. I'm Eric Spencer, President and CEO of the Greater North Dakota Chamber, North Dakota's largest statewide business advocacy organization. And welcome to the first in our Business Impact webinar series, with this one focusing on the recently completed North Dakota Legislative Management Interim Healthcare Study. Before I begin, I'd like to thank our event sponsor, North Dakota Guarantee and Title, who has made this webinar possible. Once again, that's North Dakota Guarantee and Title. And I also want to thank all of our Cornerstone members for their continued support, which is critical to our ongoing success. The topic we're going to learn about today is of great interest to our members. We hear frequent questions about what drives the cost of health insurance, because employers often see their premiums climb year after year and want to know why. During the 66th legislative session, the North Dakota Insurance Department was tasked with assisting legislative management in conducting an interim study looking into this issue. The study is unique because it looked beyond the insurance carriers and authorized the collection of data from hospitals across North Dakota. The study provides an opportunity to guide a discussion on healthcare delivery and healthcare insurance coverage in our state. Now, during the webinar, North Dakota Insurance Commissioner John Gottfried, along with Jennifer Hammer, who consulted on the report, will talk about the details of the study, including potential policy options and legislation. CHI St. Alexis Health Market CEO Kurt Schley will be providing additional comment and perspective throughout the presentation. Now, as this session moves on, we encourage all of you to submit questions in the Q&A section, and our presenters will respond as time allows. Now, for those of you who do not know Commissioner Gottfried, he is North Dakota's 22nd Insurance Commissioner. He was first elected in 2016 and just recently re-elected in 2020. Prior to serving as Insurance Commissioner, he was the Vice President of Governmental Affairs for our organization, GNDC. He's also played professional sports, has a law degree and MBA from UND, and holds the Guinness World Record as the tallest elected official in the world, although you wouldn't know it from his little picture on the screen. Kurt Schley is the Market CEO at CHI St. Alexis Health in Bismarck. And as part of that, he oversees the 287-bed medical center, as well as 7 critical access hospitals, and an array of clinics and other healthcare services in North and South Dakota. He has served in hospital leadership and administration roles throughout the country, and graduated from John Brown University with a Bachelor's of Science in Business Administration, and holds a Master's in Hospital Administration from the University of Missouri. So with that, I'd like to welcome all of you out there here, and you, Commissioner Gottfried, you, Jennifer, and you, Kurt, and I pass it on to you guys. Thank you all for taking the time.
Well, thanks, Eric, and thank you, Kurt, and Jennifer, for being here, and all the members for joining in on this. I'm going to turn a lot of this over to Jennifer Hammer, who is our consultant who helped us lead this report. As she really knows the ins and outs of the report, and was instrumental in developing the data, or I guess gathering the data and developing the report itself. What I'm going to do is provide a little bit of background on kind of how we got here. It's been a long discussion we've had at the legislative session. As far back as I can remember, even when I was working at the Greater North Dakota Chamber, regarding the true cost of healthcare. What's driving healthcare costs? And in my role as insurance commissioner, I'm able to pull data from our insurance carriers, and we do that on a fairly consistent basis. And under the law, they have to give me that data. And so we usually, when the legislature asks, John, what's the main cost of the increasing premiums? What's the main cost of healthcare? Why are these things going up? We can pull that insurance level data over, do some analysis, bring that forward to the legislative committees or legislature, have a discussion. Inevitably, in that discussion, our providers or those representing the providers will stand up and say this information isn't accurate. This information doesn't tell the full story. It's looking at charge data, not cost data, and we'll go through the nuances of that. I think the legislature, in their foresight and their infinite wisdom, last session decided that they wanted to get a full, truer picture of what's driving healthcare costs. And so they've directed my office to complete a healthcare cost analysis, which included getting information from our hospitals and our providers across the state. Now, this is truly unique. As far as I know, and Jen can probably confirm that, is we're the first state that has had this kind of look. A lot of studies have been done on the national level over the last number of years that have pulled CMS reports or pulled other kind of federal reporting and done some analysis that way. But this would be the first time that a state has really gotten to look into that hospital data. And so the one thing that I'm really proud of with this report is, you know, we worked in a collaborative nature with our providers, and it wasn't always comfortable, admittedly. But the data within this report is primarily, you know, their data. It's been primarily provided by our hospitals and by our providers. I'm proud of the accuracy of this report. We've gone round and round and had many discussions over the analysis, which we can certainly touch on. But the accuracy of the data within the report has been, I think, agreed to by everybody that it's accurate. Now, the interpretations of that data, you know, again, that's what interpretations are for. They're left for interpretation. But I don't think you can criticize a report based on the accuracy of the data. Now, this report, I do think, gives us a good look into what's going on in North Dakota. Certainly, this report was started, or the study was started prior to the global pandemic, and that did have a change in some of this information that we were receiving. We did our very best to account for that, and I think there are some adjustments that have been made to account for the COVID-19 pandemic, and I'm sure Jen will cover some of that. But at the end of the day, this report really is a starting point. You know, I don't think this is a discussion of, you know, who's right and who's wrong. You know, where are the issues? It's just a matter of, here's the data that's before us, and is there anything we can do to make our system better? Is there anything we can do to make our you know, our hospital system and our healthcare delivery model in the state better? And that's the way that I truly approach this report and truly approach the data in here. It's, again, you know, there are some things in here I think that we need to take a look at, and I'm happy to see that Kurt is on the line as well to provide his insight, because at the end of the day, I'm also not a hospital expert. I'm not going to claim to be a hospital expert. There are things that probably can be discussed by Kurt that make more sense to Kurt than they do to me. But this is a starting point for a discussion and bringing that forward to the legislature. So we're making informed decisions. We're making having informed analysis about what is actually going on, because as we know, if the underlying thing that you're insuring is expensive, your insurance is going to be expensive. And if the underlying thing that you're insuring continues to increase in cost, your insurance is going to continue to increase in cost. And we've also done a fairly significant private market healthcare insurance study. We did that going on 2 years ago now. And again, that showed that our health insurers on average are showing about a 2% loss year over year. Now I know that similarly, the hospitals are in a similar situation. And so I think it gets down to the question of, you know, we're investing a lot as a state into our healthcare system. And is there things that we need to tweak to make this more affordable for our private market? And I think this healthcare study, at the very least, again, starts that discussion. But I do want to turn over to Jennifer Hammer. She is our consultant who led the report. Jennifer is a former insurance commissioner as well from the state of Illinois. She's actually the first woman insurance commissioner in Illinois to be confirmed by the Senate. She also has served time in the governor's office with Illinois, as well as the chamber in Illinois as well. So she has a wealth of experience and a wealth of background that covers both insurance and hospitals, and was a great choice to be kind of the project lead on this study, as she's had experience on both sides of the coin. So with that, I'd like to turn over to Jennifer Hammer, and Jennifer, I'll let you to walk us through the report.
Perfect. Thank you, Commissioner Gottfried. Appreciate your background, and hopefully just want to set the tone. And I think, Eric, you can help monitor, but if there's questions along the way, we are certainly happy to answer those as they come up. So be sure to indicate if you have a question as we present the data. It would be great to have a conversation in that way. So I just want to kind of lay the landscape, first of all, regarding COVID. So the commissioner mentioned that the global pandemic came about during our study. We began back in October of 2019, November of 2019, and obviously we're pretty much getting the data we needed from the hospitals and collecting insured data as necessary when the global pandemic hit. And so we were thankful that the hospitals were able to continue to work with us through that pandemic. But overall, I would say as we did the analysis as the pandemic played out, obviously it was different for every state. You saw New York and other states have the initial impact, but North Dakota was really unique in how the pandemic presented itself. You certainly defied all of the predictions as far as expenses and claims and things we thought we would see during the pandemic. We really thought there would be an initial drop in claims due to people not seeking care, preventative care, things other than COVID care. And we saw a short dip, but as you'll see, I'll reference in the report quite a few times different page numbers. So hopefully you have that pulled up. If not, we can email it to you afterwards. But on page 8 of the report, you'll see that we really put together a chart that analyzed the inpatient revenues and things that were affected by COVID. And we think you're pretty much back to normal from COVID. So just kind of setting the COVID pandemic landscape as we start into the report. I think we also testified in the interim committee about really the hospital data and the insurer data up through 2018. And we were really lucky to get through 2019 data in time for today's presentation so that you have another year of data to really show the trends have really remained what we thought they would be. The 2019 data, although it was a sprint to get everything included in the final report, it really looked like things remained the same. So I think what would be helpful today is if we start on page 19 of the report. Page 19 of the report really outlines the 8 high-level issues that we found. That doesn't mean necessarily that you're an outlier in every piece of data within that factor, but it does mean that we noted some key findings within the report. The first one being that patient utilization measures grew by 1 to 2% per year. I think this is important to note when we talk about where patients are getting their care, if it's the appropriate care, are they getting more preventative care to prevent long-term costs? What we saw was an average of 1 to 2% growth per year. We'll talk a little bit more about the intricacies of where we saw that growth here in the additional pages. Hospital revenues and expenses grew about 7.5 to 8% per year, which obviously is a little bit high. Growth in cost per unit of use averaged 6.5% per year. Average salaries rose by 4% per year, and employment grew by 3% per year. I think there were at times, as we met with the stakeholders, sometimes there seemed to be expectations that we would find cost in places where we really didn't find it. So I think you'll see that in this report that we're not seeing some of the costs in traditional places and the hospitals that are included in this study. So it really was the top 9 hospitals that were included in this study in cities with a larger population. We don't have some of the critical access hospital data in here, putting the burden of collecting the type and volume, just the mere quantity of data we needed to make sure we were double and triple checking the data when we presented it to the economist who was on board that helped us look at this, the legislation provided for just the larger hospitals. Case mix index growth in Medicare was 1% per year, which means just a little bit less well population. Commercial payment rates grew from 170% to over 200% of Medicare rates. So that means your commercial rates, reimbursement rates to providers grew to 200% of Medicare rates, previously about 170%. So that's a pretty big jump. Patient financial assistance was only about 1% of patient revenues, and hospital compensation for top execs and physicians ranged widely between the hospitals. So we'll get into that. Okay, midway through page 19, you'll see just kind of an overview of what hospitals we talked to, what kind of data we collected, HCRS data, AHA data. So we talked to American Hospital Association, and really helping you understand that we were trying to triple check really everything in here so that we knew the data was accurate. Patient utilization measures grew by 1.2%. You can see that reported here on page 19. Among the 9 hospitals that we were collecting data from at the time, inpatient admissions were basically flat. So that is a good thing. I think we talk a lot in the population or public health space about reducing ED visits and making sure people are going to the right place at the right time, so that employers who are paying for health insurance are paying for customers that are really getting their care at the right location, so they're not overpaying for their care. We know, the commissioner mentioned this, healthcare costs drive health insurance premiums, right? So you're trying to get at what is driving healthcare costs so that we can contain those costs and reduce premiums. So you'll see in table 1, there was some growth, and I think a lot of the growth really was centered around a couple places, predominantly in the Medicaid space. And so that usually doesn't play into the employer space unless you have much lower compensated individuals and really minimum wage and other things allow. Page 21, hospital revenues and expenses rose 7.5 to 8% a year. You'll see that this space, we did flag, there are issues here. That's substantial growth in that 10-year period, and you're seeing that there's outliers, right? So there's some that hovered at 5 and 6%. Without getting further into the data, it's hard for us to know whether those were justified or not, but you'll see that there are some that really increased by 13.8% or 11.2% in non-patient, non-operational revenues. And so those are things we would flag that, you know, you want to look at. What is creating that sort of increase? We talked some with the reporting hospitals, and we know also from some of the insurers at times there are improvements or other things done that could contribute to the revenues or expenses happening there. But there are some outlying issues on those tabulations on that data. So page 21 is a significant chart to look at when trying to figure out how to reduce healthcare costs. Okay, growth in cost per unit of use averaged 6.5% per year. So this is located in both table 3 and 4. What we did is compared the average annual growth in expenses with a composite index of utilization. And so what we wanted to do is see essentially per unit of healthcare that was utilized, where are the costs on that going? Are providers becoming more efficient at providing that care? Are they having increased costs when providing that care? And you'll see that it seems like some hospital systems are really finding efficiencies and able to reduce the cost of that care where others lag behind. You know, we have a huge outlier in this space. Sanford Fargo was at 14%, where you're seeing almost everybody else at least below 8-9%, but most of them hovering much lower than that. And so it's worth noting, why are the average cost per unit so much higher in one location over another? I think we've had extensive conversations about location or level 1 trauma. We don't really believe that having level 1 trauma would be something that would necessarily increase. Most states in the nation have several level 1 trauma. Your neighbor in Minnesota has a ton of level 1 trauma centers, and we compared, you'll see in these later charts starting on page 30 that we compared with your contiguous states as well as the nation as a whole to get an idea. Where are per unit costs? Are you guys average nationally? Without just looking at the growth, let's look at whether it's reasonable on its face to start with. So I want to continue on to page 23, just being a little bit cognizant of your time, but average salaries rose by 4%. This is probably something you can all relate to as employers. So you understand, you know, there are reasons for costs of salary or employees to go up, and whether that's reasonable or not in this space, I think that's where we once again want to look at wages and benefits as a whole, and are there any outliers? In this space as well, we saw that Sanford Fargo was at 14.6%, where we had some of their competitors at 3, 4, 5, 7%, and no one up over 8 or 9 except for Sanford Fargo. So what's going on there? Why are their wages and benefits so high? Because we know one location can drive healthcare costs across the state. And that's because everyone has to be in the same risk pool or get the same product, right? And then we look at FTEs and really what does that look like? What's the average growth? We had some obviously that reduced their number of FTEs, some increased the number of FTEs. Obviously, number of FTEs is going to drive wage and benefits. And so just relating those two, wanted to put that down so you had a true understanding of where growth in employment is happening or not happening. And you can be the judge of whether that's a positive or negative data point. Average salaries, I think this is one that really on top of page 24 that you can wrap your head around. They all averaged about the same, somewhere between 3, 4, 5, and 6% annual average annual growth in salaries. St. Alexis was up at 6.1%, but there were plenty up at 4.8 and 3.2. So average growth of salaries we didn't think was necessarily something that was concerning. Case mix index growth in Medicare was 1% per year. So there are very specific data points that Medicare collects that we were able to utilize to really get a good sense of what's your case mix like. This is really the complexity or difficulty of a case. The easiest layman's term is the wellness of the patients presenting at the time. You did have a 1% increase. Doesn't seem concerning to me, but it could mean that your population is getting older and living longer. It could mean several things, but just laying out there that sometimes people want to revert. All the stakeholders at times want to say, well, the population is less well, or we're getting sicker and sicker, right? And that's why costs are going up. And this kind of just dispels that information to say that you do have an older population, that's for sure, compared nationally. But right here, the rate of illness is not going up dramatically. There was a 1% increase over that period of time, which is a long period of time. We'd like to see it going down, obviously, but page 25, commercial payment rates grew from 170 to 200% of Medicare rates. Medicare is traditionally used in a lot of different studies as the base point, the benchmark, what you compare other rates to, because it's a standard number that we can figure out, right? And so it's interesting to look at how Medicare fluctuates and how the commercial rates fluctuate along with Medicare. You are seeing a dramatic increase of commercial rates when we're computing the payment rates compared to the Medicaid or Medicare rates and the fluctuation there. And so you can see that in the chart on 25. Over the period of time, you can see the fluctuation of the private. Commercial is just private insurance, of the private commercial rates compared to Medicare on that chart. And they're broken down by hospital. So I think that's a nice way to really be able to look at them and see where the rate's higher than others by hospital, by year, compared to Medicare.
Jen, if I can jump in here real quick.
Sure.
On this piece, because this is something that we obviously care about in the insurance department and the insurance world. You know, again, as kind of the outsider looking in into our state, I'll admit I'm close to the insurance market. The comment we usually get is that from the providers, especially, is that the insurers don't negotiate, and there is no negotiation when it comes to rates. And to me, just looking at this stat right here, it would appear to me that over time, a growth of 30%, you know, from 170 to 200%, would show some of that negotiation must be taking place. There must be something going on there. I guess without, again, not having lived on the hospital side of the world, but just looking at this pure numbers, would that make, you know, does that make sense?
Yeah, I'd just say from the hospital perspective, we talk about Medicare as a compensation rate, and for those of you, you know, in the audience, whatever your product or service you provide, think in terms of Medicare rates, Medicaid rates. The vast majority of hospitals do not break even; they will take a loss on Medicare services. So when you see a multiple of Medicare at 170 or 180 or 190, that is so that the hospitals can be break even or have a small profit. And the average hospital profit margin prior to COVID was anywhere from flat to about 2%. And that statistic is really true for all hospitals across the United States, that hospitals are not able to survive on purely Medicare rates. Now, Commissioner, you made comments about negotiations with, the government reimbursements are fixed. There is no negotiation from a hospital standpoint. We have discussions with our largest payer in North Dakota, and that's Blue Cross. But by and large, our payments are fixed, and there is very little discussion or negotiation. So as the administrator at St. Alexis, if my costs go up 10, 15% this year, my reimbursement, or what I'm being reimbursed, is going to stay exactly the same. And if I would present that to the government or to, my partners at Blue Cross, they'd say, well, Kurt, you've got to get those costs under control. So hospitals are not able to pass that along to the payers in this instance.
Good. So that's really useful information. Just a couple points for reference. North Dakota is a little bit unique. There are several other states like North Dakota, but you do receive a somewhat increased Medicare reimbursement rate. Medicare, as you all know, is relative to the location of the provider, and there are a ton of different data points that go into the resource-based relative value scale that the Fed CMS uses to set those Medicare rates. And so I would argue that the data supported the fact that the Medicare rates are a little higher in North Dakota than in other states, which seems to support the idea that the preference should be that we are all working in a mutually beneficial way to deviate away from rate shifting from one type of payer to another. I don't think anybody, especially on this call, would agree that they should be subsidizing Medicare patients with the commercial rates, right? So you don't want to perpetuate a scenario where the commercial market is actually subsidizing both the Medicaid and the Medicare market. Those should stand alone from a hospital perspective. And I do want to make a couple points on the Medicaid side. Although we went into some depth, I would love, because I'm policy wonky and would love this, but I would love to get into a little more detail on the Medicaid space, but I'll flag that you have a portion of your Medicaid population that's actually paying commercial rates. And so that portion of the population obviously shouldn't need subsidized if they're paying the subsidization rate. And so you are actually uniquely situated in a way that your Medicare rates are higher. Your Medicaid has a portion of the population, the ACA expansion population, that's paying commercial rates. And so I think the argument that providers are rate takers in this space may have some validity to it in some space, but this data, especially this report, should energize you to have discussions and negotiations with Blue Cross or others in your state. We know that sometimes it's hard because all of the belly buttons are coming from one insurer and you need to negotiate with that insurer. But we also know there's tons of research out there to suggest that also providers are running a business. They don't have time to go back and forth with an insurer, and it takes time, attention, dedicated staff to have these robust discussions and negotiations with insurers. So I think you both make some really good points. I would just flag that your Medicare rates are high and a portion of your Medicaid rates are really high. Any other questions on that?
I would just say that even with Medicaid expansion, which is very beneficial, and let me first of all say that, yes, hospitals, as the administrator at St. Alexis, as part of the North Dakota Hospital Association, and I have colleagues on the call here, we want to engage in robust discussions. A healthy North Dakota, from a society, from an industrial standpoint, needs a strong healthcare system, and we don't want to be viewed as profit takers. I don't believe that we are profit takers when you see our margins. But when we talk about Medicaid and Medicaid expansion, even when we put those together, hospitals are not able to cover those costs. And with the way the insurance is set in this country, I've heard in the state, I've heard the phrase cost shifting. I've been an administrator in administration for 30 years. That is not ethical, and in this day and age, that cannot continue any longer. So it's an industry, it's a business, it is also a mission that needs to be focused on quality and outcomes. And I think that's how we have to have future discussions about how do we move forward as a state to make sure all of our residents get the services they need and at the right place and at the right time, which, going back to your earlier comments, Jen, if somebody is in the ED and they don't need to be there, I can argue that there are safeguards to protect that today, but they need to be into a more appropriate level of care, such as urgent care or seeing their doctor in their office, because we need to treat illness and identify illness at the lowest possible stage, because that's beneficial to the patient, but it's also beneficial to us as a society because it's lower cost.
Yep, that's exactly right. So I think I can agree with all of those final statements. When we get to the policy recommendations, you'll see even going a step further into the telehealth recommendations and really keeping the ill patient at home as to not infect other patients or get really quality care there. The other thing that I can also tell you that the data supports is using quality metrics that are agreed upon by all the stakeholders. Sometimes it feels like everybody's putting a new quality metric in place and you're trying to really, you can't catch up with some of the initiatives that you're trying to do because you're chasing so many different accreditation or quality metrics that are set by different stakeholders. And so we get into some of those policy solutions at the end, but completely agree that one of the ways to drive down cost is to have treatment at the right place at the right time by the right provider. So, Commissioner.
Yeah, Jen, I got a Q&A that came in. I don't know if it was to me or to whoever. And it says, Commissioner Gottfried, what is your end game for the study? Is it to micromanage hospitals through legislation? I understand the impetus behind the question. I think it touches a little bit on some of the sensitivities to having this discussion. And so certainly not. That is certainly not my goal. It's certainly not, I don't think, the last thing that we want to do is get involved in the provider discussion, because that's not what we do at the insurance department. Our goal is to have affordable insurance and regulate our insurance market so it's affordable and there's access for everybody. So no, I don't think my goal is to micromanage hospitals through legislation. I think that's kind of almost a ridiculous claim. But what I do think it is, we need to have a discussion about our healthcare costs. And I think we have not had that discussion in a fully transparent way really ever, because again, usually the data we bring forward is on the insurance side. And we'll ultimately get criticized for not having the right data brought forward. This is truly the first time we've had this data brought forward in a meaningful manner. I think Kurt's brought up some great points, and some of the discussion that we've had around the horn here is, is this a Medicare reimbursement problem? Is it a Medicaid reimbursement problem? Is it a commercial rate reimbursement problem? It takes all payers. It's going to take probably adjustments on all payers and everybody involved to solve the solution. But what I can tell you is, the trajectory we're on doesn't lead to where I think we want to go. And so if we don't start having these discussions, at least at the state level, as well as the national level, we're going to be faced with scenarios where it's getting harder to afford health insurance. It's getting more difficult to keep our services available at the hospital level. Everybody's getting squeezed. And I think we need to have some discussions on how do we do it better. So I just answered that question that no, certainly my intention is not to, I have no desire to get into the hospital space to regulate the hospital side of the world. But I think it's a meaningful discussion we need to have here at the state.
Good, thank you, Commissioner. And I think as we get further along into the policy solutions, you'll see that none of them really recommend any sort of, from the Department of Insurance Management, of the internal micromanaging of hospital operations at all. And so that should be easy to answer as we get along. And I think, this study follows up several good years of where we saw some dramatic increases in health insurance premium, and Commissioner Gottfried bring in the reinsurance program and a 9% drop in premiums. And to me, it has felt like just what is the next step to keeping either flat health insurance premiums or, best case scenario, reducing health insurance premiums. And I think it goes without saying the first thing we have to look at are costs. And Kurt made a great point. A lot of times a patient that is well is going to cost much less than a sick patient who's going to the wrong entry. So let's talk about page 26. I think we can speed through this really quickly. I'll note that this was an analysis of financial assistance, or what is commonly referred to as charity care, or patients that maybe come in and can't afford payment. We found that there was about 1% of patient revenues were related back to this type of financial assistance programs. Noting that we didn't have comprehensive 2019 data for some of this. When we went back to the hospitals, we got patient revenues, but we didn't get all revenues, so gross revenues. So just note that because the pandemic was going on, we didn't push on a couple of data points. Then you'll see what I think is probably surprising to a lot of people reading this study, a pretty reasonable representation on page 27 of top exec and physician compensation. You'll see that there really isn't a ton of hospitals out there paying their top 3 physicians or execs increasing at least annually in a rate that is surprising.
Well, and I would just say, with regards to physician compensation, healthcare is the most regulated industry in the country, and there are fair market value levels for what you pay a primary care physician, you pay a cardiothoracic surgeon. And yes, the physicians can be productive and they can generate income, but if physician compensation is significantly above what the norms are in an area, hospitals are at risk for paying for referrals. So all of this is very regulated, and it is watched. And at the same point in time, you want physicians that are productive and quality individuals, but you cannot simply pay a physician what he or she would request or what you would like to bring them into your market. It must be considered fair market value, or else you are breaking the law, because that's one of the regulations that hospitals and physicians have to work with.
Perfect. Thank you, Kurt. And I think some of that background is helpful as you navigate some of the stakeholder arguments. A lot of them are, hey, the top execs or top physicians are making so much money and they are taking all the money from the hospitals. And we wanted to just make sure we went down every rabbit hole so you have the tools in the toolbox to make educated decisions when you're trying to drive down healthcare costs. So completely agree with that. Nothing on there. There were a couple outliers, but nothing seemed extremely concerning to me. The chart on page 28 is what I think is very illustrative of some issues you have going on. Obviously, there are 50 states, and when we looked at those states and specific data points, you'll see beginning in 2010 and ending in 2019. So when you're looking at these columns, you're looking at what's the data point, then you're looking at what level were you in 2010, where did you end in 2014, and what was your growth compared to other states. The growth, the furthest right column is least helpful, I would say, in doing an analysis here. I think you can see that when you look at, for instance, how many beds per person, you have, you are 5th in the nation. You started as 5th in the nation, you ended the decade at 5th in the nation. That's pretty high. That's a lot of beds. Do you need that many beds? I don't know. I can't tell you that. I can also tell you that your operating expenses for hospitals in the nation, you started at number 2, you ended at number 1. That's not something that you want to be number 1 in, right? So what is happening there? The growth is a little bit irrelevant at this point.
I would just say, I don't mean to interrupt you, but I think I'd like to add to your comment there with, the operating expenses per person and the beds. We talk about the importance of competition in markets, and their competition is good. There can be a case can be made in healthcare that at times competition can drive up cost, but I believe hospitals will offer services, given the low population in North Dakota, when there are multiple providers in certain areas on a per statistic basis, because there's competition, there is going to be higher costs associated with that, because while there is beds in Bismarck, X number of those beds are at St. Alexis, X number of those beds are at Sanford, and we're both providing similar services, offering choice, competition, quality to the public, but you could argue that there's a redundancy of beds, but those beds are needed for there to be complementary or competing services taking place. So I think that's what is driving that figure up a little bit. And I think the per stat statistic gets to North Dakota in terms of population is a very small state. And when you look at all these services, we're averaging them over people. Our numbers are going to be much higher per statistic than a state that has a much more populace.
Good. Yeah, I think there are plenty of rural states, and we try to look at those, especially a lot of your neighbors are rural. And we try to look at those types of issues. And I think we can get into a lot of the detail of competition. You want free market, you want there to be competition, you also want there to be quality, right? And so I think this is something for constituents as voters and legislators and others to decide, but do you want every hospital providing every service, or do you actually want hospitals that specialize in that service providing all the service for the state, for several regions of the state? You know, I don't know what that perfect solution is. A lot of states have tried centers of excellence, right? They have decided, and big employers have decided, we're going to go shop all of our ortho to one hospital system, right? And when they do that, eventually what happens is the providers that are experts in that specific specialty have all the quantity, right? So you do more quantity. In theory, you'd have better quality. But those are all discussions, those are all solution type discussions to the fact that I think everyone probably should agree that you don't want every hospital providing every service, because that just means that you're going to remain number one in operating expenses per person. And, you know, obviously the operating revenues per person follow right along. You're second in the nation. You have been for the past decade. There was no change there. But what you're also going to see is drastic jumps in your ranking in the next 5 data points. So what you saw were average salaries per FTE, where maybe on paper, it didn't seem like a big deal. You look at it in its silo, it doesn't seem like a big deal that there were 4% increases on salary. Well, it may be a big deal because you started at 15th in the nation in 2010 and you ended at 8th in 2019. And the same thing with inpatient revenue per discharge. How much revenue was coming in per discharged patient? You started at 21, almost average, right, for the nation. That's how much revenue was coming into the hospital system per discharge. You ended at 6. You jumped 15 spots. So what is causing that increased revenue there? Commercial to Medicare rate ratio, we talked a lot about that. You had that big jump in Medicare rates. So you went from 30th to 7th. We've talked about why that occurred. And the Medicare case mix, you actually went down. We talked about that it was only 1% growth. And so a lot of states saw much higher growth. And so you did a really good job there. You went from 24th to 35th. Medicare revenues per enrollee, third in the beginning, second. Medicare outpatient revenues per enrollee. So what is this flagging? A certain population, a certain entry point, the Medicare outpatient revenues per enrollee, you're number 1 in the nation. So you're paying the most in the nation. You were in 2010, you're still doing it in 2019. Medicaid revenues per enrollee, you started at 3rd, you ended in 1st. I think we all know why. You have your commercial rates in that expansion population. Private patient revenues per private insurance enrollee. So the revenues per private insurance enrollee went from 4th to 3rd. Also not something you want to be high in. And then patient financial assistance, you were worst or 50th in the nation and you ended 35th. So I don't think, you know, a little bit of gain there. Inpatient discharge, we go through each of these data points in the next few pages, but I want to note that if you can see the maps on the screen, the darker colors are, you know, going to indicate worse and the lighter colors are indicating better. So when you look at North and South Dakota or your neighboring states, you can tell how you fared. So growth in inpatient discharges, you guys are pretty much flat. The next chart shows the same thing. You're going to look at inpatient days. This is where we talk about, I personally think this data point is significant, but sometimes when you see a decreased rate, what you're going to see is an increased stay. And the intent, really, you know, medical necessity, although there's a ton of things that drive it and a ton of regulation and provider licenses that protect some of these things, sometimes what you'll see is if you see a heavy monopolistic insurer in a state, you'll see the provider's response is increased stay. So the length of the stay increases when, and it may not be a systemic demand from someone up top, right? It may just be something that occurs. But what you're seeing here is a somewhat significant compared to other states growth in inpatient days. We show it both in just the days and then also per 1,000 constituents. And so you'll see you're pretty high when you look at it per constituent. Looking at page 34 is the stay as a whole. And so you can see there, you guys are #1 in the nation. We are intentionally lacking data from a couple states there. You'll see some states lack data. Like I said, we like to get triple confirmation on things. So you'll see some blanks if we couldn't triple confirm it. Occupancy rate. Occupancy rate has been such a point of discussion throughout the pandemic. Everybody wants to know what's bed availability, how busy are these institutions, are there going to be enough ventilators, all of those questions. And so it also drives whether or not you need access to critical access hospitals and some of the other types of institution that you may have access to in your state. And I would say the occupancy rate was at 54%, not extremely high, not extremely low, kind of in the middle. So can you sustain losing a couple hospitals or things? Maybe, but obviously another point for the legislature to get into the granular detail of whether the number of hospitals is needed. We don't get into that type of analysis here. We just basically show whether you have enough occupancy. And I think this is another data point you would consider in black swan planning. So planning for another global pandemic at some point, I would consider occupancy rate to be one of those things you'll want to look at and make sure it's where you want it to be. There's no real data point that shows where it should be. And then going along that same line, beds per 1,000 residents, you have 3.1. That's on the high side. You'll see there's a couple other states up at 3, but not many. So you have quite a few beds in the state. I know a lot of things go into bed calculation and availability and those sort of things, sometimes even staffing numbers, but.
Real quick, Jennifer,
yeah.
we did have a comment, and I'm just gonna let reply real quick. I think I might even know the answer to this, but someone made a comment about the beds per capita, that they thought we had a bed shortage during kind of the heat of this winter. And Kurt, I don't know if you just want to offer a brief comment on that, but it was related to staffed beds. Is that correct?
I would, when you talk about, I think these statistics are referring to licensed beds. And due to improvement in technology, what used to be in the hospital no longer needs to be in the hospital in terms of a patient. So there's licensed beds, and there's also staffed and in-use beds, and that number is a lower number, and that's what we saw when the pandemic hit. That we had, you know, at St. Alexis, we had 17 ICU licensed beds, but our normal operating census prior to the pandemic was 12. And so when the pandemic hit and we needed to have 17 patients in the ICU, we were licensed for that, but do we have 17 staff beds? And that's where hospitals, and St. Alexis included, worked on very aggressively getting additional nurses into the hospital so that we could have our operating beds try to match up or line up with what our licensed beds were.
Well, thank you, Kurt. And I just have one other question. I don't know who the appropriate person is, but how are add-on payments for Medicare, and for example, DSH, MedEd, Soul Community considered in the Medicare to commercial rates comparison among the various providers? John, I don't know if that's a question for you or maybe part of a longer conversation.
I'm going to see if Jen's got any idea on that one.
Yeah, so normally these dish payments and other payments to providers and things aren't necessarily considered in the Medicare rates, and it's my understanding when we look specifically at rates, those weren't something we considered, but we can certainly circle back with you. I would want to talk to the actuaries and economists on whether they put those dish payments in there. Those can be significant payments, as Kurt can attest to, but they are also justified, right? The federal government does an analysis as to whether you should be receiving those payments or not. So Kurt, I don't know if you have a comment there.
Hospital is eligible for dish or disproportionate share payments on a periodic basis, depending on the types of populations, patients they've treated, and the severity of those patients. I would just say, again, with regards to Medicare, and you've heard comments about hospitals in North Dakota get an additional payment. Hospitals cannot survive on Medicare reimbursement. So it's, even with those additional monies, it's lowering the loss that you have on a Medicare patient. So you may be saying, well, then why is it set up that way? Well, the government is the largest paying source for hospitals, and we are in the business of caring for people, but Medicare payments, with or without all these things that Jen and other folks are talking about, it is not a situation that is hospitals are able to sustain that.
Good, thanks, Kurt.
Sure.
Great, and I'll just let you guys know we have about 9 minutes left. I know there's a lot of data in this, but let you guys try to kind of finish out the conversation, and maybe at the end, John, talk about maybe some next steps, because obviously there's a lot of this study presented a lot of data, but there's a lot more to the onion in terms of understanding all the dynamics in healthcare.
Sure, thanks. So I'll speed through a couple of data points and probably just toss out some of the solutions. Obviously, want robust stakeholder conversation around any solutions, but staying on page 40, I'll flag again, you are outliers in operating expenses, both in just pure operating expenses by growth. You had a huge growth alongside South Dakota. So there was some sisterhood there between North and South Dakota. You had about an 8% growth. And hospital expenses per state resident, you were the highest in the nation, right? So per resident, you were looking at $5,600 per resident, and South Dakota was about $5,000 per resident. But I want to kind of skip through. You'll see some other operating revenues. Obviously, those normally go right along expenses on page 43 in the national comparison there, and wages and salaries, as well as inpatient revenues that we talked about before. Commissioner Gottfried, would you prefer that I skip along to possible solutions or finish out the data points?
I think we can skip along to the solutions. I think I will just say that this is, for those of you on the call, you now have access to this report. It's also available on our website if you lose access or you want to go find it again. Just encourage you to review it. I mean, I think that there's some insurance data in there as well. And I think as we get to the solutions, again, all the solutions that we've talked to have been agreed to primarily by just about all the stakeholders, right? And we threw literally everything at the wall. There are some good ideas and some bad ideas absolutely within there. But I think when we're focusing around medication optimization, making sure folks are adhering to their medication, where, obviously we all have a role to play in that, in the insurance side, the hospital side, even the pharmacy side. You're also looking at, integrity audits, making sure that they're in the right plans at the right times. And so we're not paying for folks to be on Medicare or Medicaid when they shouldn't be on Medicaid. And so we're doing some of those integrity audits. And so I think as we get to this data, we look at the solutions. These aren't necessarily solutions that are going to be driven by the insurance commissioner. They're not going to be probably driven by, they need to be a system-wide discussion that's driven. And I'll tell you, the one thing that I'm primarily probably the most frustrated with is that we spent the time on this study, brought it forward to the interim legislative committee, and I don't think that there was never really a full discussion around the solutions going forward. With that committee, for whatever reason, kind of died at the end of the interim, and so now we've got this study kind of sitting here with that'll probably likely take on, the solutions will probably continue to evolve in the next interim and have more discussion around it. But I think as you look at these solutions, they're primarily, I would say, low-hanging fruit that we can all agree on. So Jen, I'll let you touch on them.
Great, that's super helpful. And I think you talked about the main theme is getting at quality healthcare, talking about the #1 healthcare cost driver. We know there's been tons of research done on healthcare optimization, medication optimization. I apologize, but really looking at those comorbid populations that have 5 or 6 meds, a couple diagnoses, chronic illness, and looking at making sure that this system of healthcare is addressing and providing them the tools that they need to stay well and don't have to come to an entry point, hopefully, right? And so how do we get to that? There are tons of options. There is changing the individual and small group market through benchmark plans. It's looking at health homes in the Medicaid space, utilizing current quality metrics, looking at pharmaceutical schools, medical schools, and saying, hey, for your current education platform, as well as currently licensed individuals, we need to look at continuing education and things that focus on medication optimization. These patients need to understand what they need to take and when they need to take it to make sure that they stay well. We looked at value-based benefit design, CAPS. We talked a little bit about telehealth, but we also talked about the fact that your reinsurance program has been phenomenal, right? You had a 9% reduction in your health insurance premiums. That is crazy good. And so how can you bolster that program? Well, there's also the opportunity to bring some private capital into that program and see an even larger return on that reinsurance, which is one of those things that's just kind of a no-brainer when you look at it. Direct-to-consumer pricing, the ability to shop, right? We want consumers to be informed and know what they're purchasing, when they're purchasing it, what they're going to be paying out of pocket. But then we really start talking about program integrity throughout the state. We can all rally around integrity, right? You want only people who are eligible for Medicaid on Medicaid. You want only people who are eligible for the state employee group health plan on the state employee group health plan. That's because it's rated in a way that the insurers are giving a rate based on who's eligible, right? We want them to be getting their coverage in the right location. And so looking at, you know, what do those things look like, and then kind of coupling that with coordination of benefits, making sure if there's a couple coverages that the right one is paying. And then I talked about this before, but you really do want to start thinking through risk planning for the future. What does it look like to have another pandemic? Do you have enough bed space? And we talked about bed space. What does that actually mean? We know it doesn't mean occupancy rate. What does it mean? But then also looking at those small group and other markets for small employers and large employers alike. And what are some of the things that really we could suggest to the legislature that they consider in those markets? Making sure that they have the ability to get a good product out to their employees, and what does that look like? And so those are kind of the action items that we looked at. Some of them have a longer duration of implementation. Some are quick fixes, but really kind of just throwing everything out there so the legislature has ideas to consider. I think there's probably additional data that would be helpful in considering some of these things, but really thinking through, we started with 30, 40 solutions, and as we met with different stakeholders and things, we're able to narrow it down to the ones that we thought were actual viable solutions in North Dakota. And we haven't talked much about transparency, but obviously everything I talked about with right to shop, informed consumer, all of those things go back to the ability for everybody to understand what's happening in the marketplace so that there isn't unjustified finger pointing. So I'm happy to answer any questions if people want to put things in.
About
chat.
2 minutes left, so I don't know, Eric, is there anything else, or Kurt, I want to give you the chance to have a kind of the last word if you'd want it, or Eric, or however you want to handle this.
I think a lot of things have been discussed about solution, and I think we need to pursue them actively. I think some of these are already in a state of development, like telehealth. A good thing of the pandemic was the rapid technology deployment of telehealth, and we cannot go back on that. Transparency, absolutely. We've all heard horror stories of people coming into a hospital and getting a bill, and we want to avoid that. We want to make sure our services are cost effective and there are no surprises. And the key to me is health, and how do we promote a healthy state? How do we then have a system in place, a healthcare system where we identify illness and accidents at the earliest possible entry point so that it is quick recovery for the patient, and then less cost for us as a state, as employers, and costs coming into the hospital, because no one wants to be in the hospital unless you're going to probably deliver a baby. So lots of things for further discussion, and I'm speaking on behalf of the NDHA and my colleagues. We want to be part of that dialogue as healthcare providers, because for us, it is a mission and a calling. So appreciate the opportunity to talk today.
Well, as everyone who's tuning in knows, this is a complex topic, but I really appreciate you, Commissioner Gottfried, you, Jennifer, and you, Kurt, taking the time to talk to us. Obviously, this is not going to be solved tomorrow or this session or the following session. This is a complex issue, both here in North Dakota and across the country, and requires probably federal work at some point. So with that, I want to thank everyone for coming today. I certainly want to thank our sponsor, North Dakota Guarantee and Title. I'll tell you that our next session is going to be on February 9th. It's going to be a moderated conversation on how higher education is changing their workforce preparation because of all that 2020 brought. The Department of Career and Technical Education, the CTE Director, Wade Sick, will engage with college presidents from UND, BSC, and the University of Jamestown. You can go to our website to check it out at ndchamber.com. And again, thank you all for taking the time to spend a few minutes with us today. Thank you.